Good evening. Good
Good,
evening.
good evening, everyone. This is Dr. Mansi from Homeopathy 360, and we are back again in the Home Talk 2025 series with Homeopathy 360 and in collaboration with Paran University. So we have Dr. Gaurav sir and on this platform, and he's going to share very informative insights on Sciatica. And we have Dr. Z with us. Now it's time to hand over to Dr. Z to please begin this webinar.
Hello and good evening all. Myself Dr. Jolly and
Sorry.
I would like to introduce the speaker today. He is the principal of Ahmedabad Homoeopathic Medical College and he has been the professor of Department of Physiology and Biochemistry. He is also the NAAC coordinator. He has been invited as guest speaker at various national and international seminars. I would like to tell you all that Sir has also done publications of various research papers in national and international peer-reviewed scientific journals. Sir has also been doing webinars with Homeopathy 360 on different topics. So I would be very proud today as introducing him as I'm also pursuing MD from Ahmedabad Homoeopathic Medical College. We have seen Sir working so hard for the college and hospital as he is also the superintendent of the hospital. So now I would like to request Sir to start his session on sciatica and homeopathy with this webinar series. Thank you, sir.
Yeah, thank you. Thank you. Thank you, Dr. Mansi, and thank you, Dr. Jolly, for your kind introduction. Uh, yeah, I would at the onset, I would like to thank Dr. Mansi and Homeopathy 360 for inviting me. As Dr. Jolly rightly said, in the past also I have collaborated with Homeopathy 360, and it has always been a good experience whenever we get connected. And this is again another platform wherein I'll be able to share whatever knowledge I have in respect to Sciatica and homeopathy. So let us just begin. I'll try and share my screen just a second.
Yes, sir, sure. Thank you, Dr. Jolly, for the introduction. And we are good to start, sir. You can share your
Yeah,
screen.
I'm trying to share my screen. Just a
Okay.
second. Hope my screen is visible.
Yes, sir. Your screen is visible.
Okay, Jolly, it's visible
Yes.
clearly, right?
Yes, sir.
Yeah, okay, fine. Fine. So, as correctly mentioned, we'll be talking about sciatica and its homeopathic management. I've kept the title short and simple because I think nobody nowadays is averse, or I don't feel that nobody knows what sciatica is, because it has become a very day-to-day condition, and many patients, even in our hospital and even in our personal OPDs, all the doctors may be encountering patients with sciatica day in and day out. It has become so common. And at the onset, let me tell you, sciatica being a condition which is obviously related with the sciatic nerve, uh, it has a lot more to do with our day-to-day lifestyle. Majorly our body postures, majorly the way in which we do our day-to-day routine. And whenever patients come to us, or specifically whenever the patients consult a homeopath, they don't know the small nitty-gritties of how and why sciatica is being caused, and how it can affect your day-to-day routine. So I would like to stress upon these points of the causes of sciatica during my today's presentation. At the same time, I would also like to focus on how prevalent sciatica is. See, why I would like to focus on it is because when we know the prevalence and the incidence, we can very well do research on certain topics. And whenever we are doing research on certain topics, be it sciatica or any other topic, the prevalence rate and the incidence rate plays a very crucial role during our research. And as I told you, whenever we want to put down our findings after any study or after any research findings, so we need to categorize things in certain ways. Like we need to categorize a particular condition based on the causes from which that condition is taking place. We need to categorize, maybe in certain cases gender wise categorization needs to be done. In certain cases we need to categorize it according to the what you can say, the therapies that the patients are taking. So there are many ways in which we can study or look upon that condition. And when I mean homeopathic management, I do not speculate that each and every case of sciatica is cured by homeopathy. By law, also we cannot categorically say that homeopathy can cure each and every case of sciatica. But at the same time, I would reiterate the point that definitely in many cases of sciatica where the causes are such which are controllable. So if we are able to control these variables or causes for that matter, and along with that, if we suggest patient a good healthy lifestyle, if we suggest physiotherapy in certain cases, and along with that, whenever we give our constitutional homeopathic medicines, and in very acute severe cases, sometimes whenever we give specific medicines also, we are definitely able to help the patient in reducing the sufferings of sciatica. So as I told you, this is how we'll go through the presentation, wherein I will tell about the certain anatomical points related to sciatica. Then we'll discuss about the certain, what you can say, the causes which are most frequently encountered in cases of sciatica. Then how we can, or what are the treatments that are available nowadays for sciatica. We'll focus on that. I'll also share you some of the yoga postures which are very beneficial in treating sciatica, and obviously about certain repertorial approaches, certain miasmatic approaches, certain materia medica approaches. So this is how we'll go through. And at the end, if time permits, I have included some of my cases, which I'll be sharing with you all just for your, just for the knowledge sharing point of view. So yeah, whenever we talk about sciatica, it is not a new entity or a new, what you can say, a terminology that has cropped up in just a few years or so. A second, I think my slides are not moving. Jolly, are my slides moving?
Sir, it's only the first slide, the heading one and your name.
Okay, just a second, I don't know. Still not moving, right? Yeah, now it has moved, I think so.
Yes, sir.
Yeah. So as I told you that Sciatica is not a new entity that has cropped up within this few years or so. It has always been there. For that matter, whenever we talk about even the Greeks or the Romans or the Hippocrates or even the ancient Indian medicine, there has always been a reference of Sciatica given in the ancient medical texts. So, as I have just collected a few literature or a few points related to the history of sciatica, there were different views or different opinions that everyone had. Like, for example, Hippocrates, he believed that the disorder, that is sciatica, was more prevalent during the summer and the autumn months. And the reason that he gave was that due to the seasonal powers, or during this particular season, the action of the sun was responsible for drying up the fluid that is present in our joints, and that is why it is causing or producing sciatica. So this is what he believed. And even like the Greeks, the Romans also continued to confuse sciatica with various other pathological processes such as gout or osseous tuberculosis or dislocation of hip, and even for that matter poliomyelitis. So like what happened was there were or you can say there was a very thin line of difference while diagnosing sciatica in the ancient times. Obviously they did not have the liberty or the facilities of investigations that we have nowadays. I'll go through the advanced what you can say investigatory approaches that we have nowadays. But in those days, during the days of Greeks or Romans or even Arabs, so as we all know, they were also very much into the medical literature. So they did not have this, what you can say, the benefits of investigation, but they were slightly able to diagnose that there is some condition which is resulting into a certain kind of pain. As we all know, the pain of sciatica, it's a, what you can say, it's a very characteristic pain that a patient experiences. So yes, as I told you, and even in the Indian, what you can say, Indian literature or Indian medicine, the concept or marmas was there. So although clear description of sciatica is not even available in the Indian medical literature, but they told or they thought that the Kakundram marma, which is located approximately in the lumbosacral area, whenever that marma, the Kakundram marma, it got exposed or it got injured, so the patient would feel the loss of sensation and paralysis in one of the lower extremities or both the lower extremities. So from this literature, whatever I got, I can say that Indian medicine at that time also was very near to the diagnosis of sciatica. Because as we all know, the lumbosacral trunk, from where actually the sciatic nerve arises, this lumbosacral trunk is the region or is the area from where all this problem starts. The causes may be like innumerable, but actually that is the point of concern, the lumbosacral area or the lumbosacral trunk. So the Indian medicine, they believed in this marma and they were of the opinion that approximately in this area something is happening which is leading to loss of sensation or paralysis in one or both the lower limbs. Now, when I say that patients experience loss of sensation, patients experience tingling, patients experience numbness in one or both the extremities, but the most worrisome part for any individual is when the individual starts experiencing pain related to the sciatic nerve. See, whenever you have tingling or numbness, in many cases it is bearable, but when it goes to the pain level, the pain of sciatica can be so excruciating that it may not allow any individual to perform his or her daily routine also. And when I was going through the literature for this presentation, I found out that actually researchers have managed to measure different degrees of pain. And they have even given the unit of pain, which is known as DOL, D-O-L. Now, why I am concentrating on this point of pain in my initial presentation is, you will see in my later presentations that whenever we want to measure the level of improvement in a patient, we need to gauge the patient on the degrees of pain, on the degrees of tingling, on the degrees of what you can say numbness, on the degrees of claudication difficulties that the patient have. And for that, a simple scale that we use, everybody knows, is the VAS scale, that is the visual analog scale. Along with that, specifically for sciatica, there is a questionnaire that has been developed. That is the DN4 questionnaire that has been developed, which gives us the exact idea of how the patient is feeling after the treatment or during the treatment. And in that, whenever we judge the patient, in that, pain is a very important entity. So that is why I have included this. Now, there are, like, as I told you, there is a unit of measuring pain known as dole. So there are 11 possible different doles that a person suffers from or may suffer from. But to make it concise, we can say that, or we can categorize pain into three categories. One is a pain you can forget. Definitely you are having pain, but you can forget that pain. Second, a pain you cannot forget. Okay, so that is the second category of pain. And the third and the most, I can say, worrisome is a pain that makes you forget everything else. So this is how you can classify the pain of your, or the suffering of your patient, like a pain, whether the patient is able to forget that pain. Second, a patient is not able to forget that pain. And third, the pain is so excruciating that it is making the patient forget everything else. So this is how, or this is the important point which you should keep in mind while taking the follow-up of the patient. Now, just, just brushing up about the brief anatomy before going into the actual topic of sciatica. Like in human anatomy, everybody knows that there is a sacral plexus. It is a nerve plexus which actually provides motor and sensory nerves. Now, the nerves that are coming from this sacral plexus, they usually supply the posterior region of the thigh, most of the lower leg, the entire foot, and some part of the pelvis. And it is the part, this sacral plexus is actually the part of the lumbosacral plexus, and it emerges from the sacral vertebra. So the sacral plexus, you can say, in toto, it comprises of the lumbosacral trunk, the divisions, the anterior divisions of the first sacral nerve, and some of the portions of the anterior division of the second and the third sacral nerve. Okay, and this nerve, after like forming the sacral plexus, they come together, they converge together near the greater sciatic foramina, and they form a band. Okay, and this flattened band in itself, when it comes out of the greater sciatic foramina, this flattened band of the nerve, it continues itself as the sciatic nerve. This is how actually the sciatic nerve, what you can say, originates. In the next slides, you can see the pictures that I was talking about. I have just given the arrows. You can clearly see the lumbosacral trunk, the superior gluteal and the inferior gluteal nerve, and how after coming out from this foramina, the sciatic nerve takes place. In the next slide, you can see it more clearly. The dissection picture. You can see some of the muscles which are in close relation or close proximity to the sciatic nerve. Now, the other nerves that you saw in the previous slide, they are also important. These muscles, they are also important because basically the sciatic nerve, whenever it is hampered, whenever the function of the sciatic nerve is compromised due to any cause, these are the muscles or the nerves or the areas of your body which will be mostly affected. It may not be possible that each and every patient might be having the similar kind of sensation or pain, whatever you call it, or the symptoms, but actually these are the regions of your body wherein the sciatic nerve might affect. Now, as I told you, and as everybody knows, that it is the longest nerve in the body, comes out from the spinal cord through the, and runs through your lower back, goes through your buttocks and your legs, and it is actually responsible for the movement and feeling in the legs and the feet. Now, basically, sciatica is nothing but a set of symptoms, and this set of symptoms includes pain, as I told you, which may be caused by general compression or irritation of one of the 5 spinal nerve roots that give rise to each sciatic nerve, or by compression or irritation of the left or right or both the sciatic nerves. So this is actually a set of symptoms. Okay. Now, what happens? What are the complaints with which the patient comes to us? So usually patients may complain of pain while walking or standing, but at times there might be reverse of this also. Reverse of this means the patient will feel worsening of the condition whenever he or she is resting, or whenever he or she is in the lying down or the sleeping posture. So that is what is characteristic for us. That should not happen, but that is what is characteristic for us. And the patient has, like in such conditions, the patient does not have any option. He or she has to roam about or walk about continuously, or in some conditions has to lie in an uncomfortable position in general. Why? Because it is giving relief from the sciatic pain. Then the pain, as I told you, is for, in the lower back, buttock. In addition to pain, there is sometimes severe numbness, muscular weakness, pins and needles or tingling sensation, difficulty in moving or controlling the leg. See, you might have patients who complain of restless leg syndrome. And sometimes it happens because this keeping the legs in a continuous moving posture or position, or in a restless condition, actually gives relief to the patient from the symptoms of sciatica. And that is why patient develops this restless leg syndrome. So it is important to judge why the patient is having this. Along with that, as I told you, muscular weakness. See, again, it is as important as pain, because if there is muscular weakness in your gluteus maximus or your semitendinosus, this group of muscles are very important for your proper posture or your proper walking. If this is compromised, your posture will be compromised. So this is very important. Now, as I was talking about the prevalence and incidence, currently it is said that sciatica occurs in about 1 out of 100 people who have low back pain. So retrospectively speaking, 1 out of 100 people who have low back pain, the cause might be sciatica. So either way you can say it is hampering the normal lifestyle of the patient. It has also been reported to occur in 1 to 10% of the population, most commonly in the age group of 25 to 45 years. And in general, an estimated 5 to 10% of the patients with low back pain have sciatica, whereas reported lifetime prevalence of low back pain in the general population ranges from about 49 to 70%. See, understand the severity of low back pain. And if you say that about on an average 50 to 60% or 55% of the people suffer from low back pain in their lifetime, and out of them 1 out of 100 the cause is sciatica. So you yourself can judge how prevalent this condition is in the society and how much painful it must be. So this is the importance of prevalence. Now coming to again sciatica, for the academic point of view, even you can classify it into, like, you can classify sciatica depending upon the duration and depending upon the origin of pain. So if you want to classify depending upon duration, it is either short term, what we call it acute sciatica, or long term, which is known as chronic sciatica. Now in chronic sciatica, one thing to remember is, obviously it persists for a longer period of time, but usually it requires some kind of physical therapy. Now by physical therapy, I mean the patients of chronic sciatica will require some kind of exercise, some kind of what you can say, adjuvant therapies like applying or hot or cold fomentation, and in rare cases, surgery might be required depending upon the cause, as I told you. So yes, this is what is important, because for your patient or for a doctor even to guide the patient, it is very important to know whether you will be able to take care of the sciatica only with some kind of physiotherapy and with your medicines, or the patient requires some additional intervention. By additional intervention, I mean surgical intervention. Okay. And another classification that can be done is depending upon origin of pain. So true sciatica, depending upon origin of pain, one kind of sciatica is true sciatica, where actually the sciatica is caused by compression of the lumbar spine nerve root, and it may be because of a herniated vertebral disc in the spine. And another type is pseudo sciatica, that is also known as false sciatica, in which it is caused due to compression of the peripheral regions of the spinal nerve. Now, don't go by the word pseudo, that is false, or you might not confuse this with some kind of a what you can say, the patients might come up with certain sensations randomly. No, it is not like that. In pseudo sciatica, actually there is not the direct compression of the spinal nerve, but the compression of the peripheral regions of the spinal nerve. Okay. And this may happen because of sitting or standing in a particular position for a longer period, sitting with wallet in your back pocket, sitting on chairs with a high seat that puts constant pressure on the hamstrings. See, by these causes, you might be able to judge about what categories of patient might come to you. As I have encountered many patients of sciatica, I have patients, majority who belong to the IT field, wherein there is prolonged sedentary seating. Okay, I have particular male patients who have complained of sciatica, and we have come to the conclusion that the irritation was happening because there is a tendency of males keeping their wallet in the back pocket, and over a period of years, when this habit is there, it might in some cases result into compression of the nerves. So that is, it might seem funny, but that happens. And again, as I was talking about occupations, we have tailors, we have bus conductors. Okay, and so on and so forth, because these occupations demand constant involvement of the lower limbs, right? So this is very, very important while treating the cases of sciatica. Coming to the important point of causes or etiopathogenesis, the most common, as you all know, is the spinal disc herniation. So whenever there is herniation or the disc herniates, okay, it might compress your spinal nerve, and it might lead to the symptoms of sciatica. Like as I have written over here, mentioned over here, a herniated disc is referred to sometimes also as a slip disc, ruptured disc, bulging disc, or protruding disc. All these terminologies are one and the same. Ultimately, it comes under the head of herniated disc. Okay. Along with that, as you know, bulging disc is also known as a contained disc disorder. What does this mean? It means that there is a gel-like center, which we call as medically known as nucleus pulposus. It usually remains within the annulus fibrosus. It does not come out. Okay, so this is what usually happens. The disc is herniated, but there is no rupture. And because of the non-rupture, the nucleus pulposus is present within the annulus fibrosus itself. But when the herniated disc occurs, it is when the nucleus breaks through the annulus. Okay, it is also known as a non-contained disc disorder. When the nucleus remains inside the annulus, it is a contained disc disorder. When the nucleus comes out of the annulus after rupture, it is known as the non-contained disc disorder. So as you all know, there are various consequences of this. what are the consequences? Like it does not, like it is not that it causes only the direct compression of the nerve root, but the disc material which bulges out, or I can say the correct word is which oozes out, it in itself contains a acidic chemical irritant known as the hyaluronic acid. And this hyaluronic acid is also responsible for causing inflammation. So what is important to understand over here is, if there is a herniated disc, sometimes it might directly irritate the sciatic nerve. But in some conditions, this herniated disc does not directly irritate the sciatic nerve, but when it ruptures, the content, that is the hyaluronic acid, which is acidic chemical irritant, it comes out and goes up to the sciatic nerve and irritates the sciatic nerve and causes inflammation, which ultimately leads to the symptoms of sciatica. But in both the cases, nerve compression and irritation, it causes inflammation and pain, often leading to, as you all know, numbness, tingling, and muscular weakness. Another common cause is stenosis, that is spinal stenosis. Everybody knows stenosis means narrowing, which occurs in the lower spine. And because of this, the lumbar and sacral nerve roots may get affected. And this condition typically results from a combination of one or more of the following conditions. Like, why does this stenosis happen? The causes are enlarged facet joints, overgrowth of the soft tissues, or a bulging disc which is placing pressure over the nerve roots when it is exiting the spine. In cases like, sometimes what happens is patients directly come to you without any investigations. So there are certain maneuvers or certain symptomatologies from which you can judge that what can be the cause of sciatica. Obviously, investigation is important, but you can judge about the approximate cause of sciatica. Like, if the pain is usually positional and it is often brought on by activities such as standing or walking, and it is relieved by sitting down, you can think about spinal stenosis as one of the causes of sciatica. Okay, so this is how you can, like, before investigation also, you can come to the conclusion of causes. Another cause is piriformis syndrome. Now, piriformis syndrome is somewhat related to the thing that I was telling you about, keeping a wallet in the back pocket and that wallet compressing your sciatic nerve. So, piriformis syndrome is named after the piriformis muscle and the pain caused when the muscle irritates the sciatic nerve. Okay. Now, why does this happen? Because anatomically, the sciatic nerve goes below the piriformis muscle. It is said that sciatic nerve runs under the piriformis muscle. In 15% of the population, it runs through the piriformis muscle rather than going beneath the piriformis muscle. It goes through the piriformis muscle. Okay, this condition also has another name known as entrapment neuropathies. When a nerve goes through a particular muscle, through the muscle, when it anatomically that is not correct and it is going through the muscle, and the muscle is causing entrapment of that particular nerve, that condition is known as entrapment neuropathy. So in that condition, patient might suffer from sciatica, and colloquially this terminology is also used as wallet sciatica, because since a wallet, as I told you, you carry it in your hip pocket and it may compress the muscles of the buttocks and the sciatic nerve which is running through the piriformis muscle. Okay, so that is one cause, piriformis syndrome. Another cause is spondylolisthesis. What happens in spondylolisthesis is it is characterized by one vertebra in your lower spine slipping forward over an adjacent vertebra. For example, L5 vertebra slipping over the S1 vertebra. This might result into spondylolisthesis. So when a vertebra slips and it gets displaced, various spinal nerve roots get compressed and leads to the sciatic leg pain. So this spondylolisthesis, the another important thing to keep in mind regarding this cause is it may be developmental, like it may be present since birth or may develop during childhood or may be acquired from some kind of a spinal degeneration, trauma, or some physical stress. So with a combination of disc space prolapse, fracture, the vertebral body slipping over another adjacent vertebra, the nerve, sciatic nerve gets pinched and it exits the spine and results into development of sciatica. Another, obviously, I'll not go into the detail. Trauma can be of any kind, like the impact that occurs from the trauma. It might result into fragments of broken bones also, which over a period of years keeps irritating your sciatic nerve. Tumors, as you all know, they are not that common, but at the same time, they are not extremely rare. The tumors can occur inside the spinal cord, within the meninges that cover the spinal cord, or in the space that is present between the spinal cord and the vertebra. So, yes, and again, at the same time, extra spinal involvement of the sciatic nerve by primary malignant tumors, or even in some cases, metastasis of some of the other tumors like bone metastasis from a breast cancer. It might happen, and in some cases there are metastasis in the greater sciatic foramina, which is metastasis because of the actual cancer present in the endometrium, known as endometrial carcinoma. So you cannot deny this fact also. Now, sacroiliac joint dysfunction. This joint, which we all know, is located at the bottom of the spine and can irritate the L5 nerve root, which lies on the top of this joint. Okay, now these were some of the common causes. Now coming to the risk factors. Now, as I told you in the prevalence slide also, that usually it occurs between 25 to 45 years of age. But over a period of time, as the age progresses, age-related changes also occurs in the spine. And as you grow older, like in the age group of 45 to 64, 65 years of age, after 30, your intervertebral disc, they start deteriorating and growing thinner after 30. So when you are in the age group of 45, 50, 55, the incidence of sciatica might increase, and obviously it increases more in women at the time of menopause, because as we all know that the chances of osteoporosis in women after menopause increases. So that estrogen and progesterone theory, we all know. I'm not going into the details of that. Along with that, occupational factors, obesity and prolonged sitting, they are another risk factors which may give rise to sciatica. Apart from the causes and the risk factors, there can be spinal abscesses or muscle strain or some kind of pelvic fractures or infections or some kind of inherited disorders of the connective tissue, which might result into sciatica. Another important terminology I've kept this apart from some cause is cyclical or catamenial sciatica. Now, this is a new terminology that has come up nowadays. Now, what does this mean? That endometriosis may compress the sciatic nerve within the pelvis, in the gluteal region, or within the sheath of the sciatic nerve. Now, typically, patients who suffer from catamenial sciatica, they present with pain in the hip and the buttock, radiating to the leg and the foot few days before menstruation, and it progressively becomes more severe and automatically subsides after 2 or 3 days or about 2 weeks after cessation of menses. So over here, particularly in females, the cases of pain of sciatica or the development of symptoms of sciatica, they are related to the onset of menstruation during some cycles or after cessation of menstruation. So if this kind of condition you see in your patient, you can categorize your patient into cyclical or catamenial sciatica. Now there are various tests. As I told you, investigations are there. Certain symptoms are there which guide you about the cause also. But certain examinations are a must before categorizing the patient of sciatica, or before putting the patient into the bracket of sciatica. You need to perform certain tests. Like, I'll not go into how to perform all these tests, but I'll just suggest you some of the tests which are must do test for sciatica patients. First and foremost is the SLR test, which we call as the straight leg raise test, or also known as Lasig sign or Lasig test. Okay. Important point I'll describe over here. Whenever you perform SLR on a patient, remember the sciatic pain in the leg is produced from 0 to 30 degrees. If it is produced when the leg is at about 30 degrees, the cause is nerve root compression. If sciatica is produced when the leg is between 30 to 60 degrees, the cause will be sacroiliac, some kind of sacroiliac disease. And if the sciatic pain is produced when the leg is beyond 60 degrees, then it suggests that the cause is some kind of a lumbosacral condition. So even this simple OPD test might guide you towards what can be the what you can say potential cause leading to sciatica. And this is the like technique. I'll not go into the details. Another test is you can do this. Yes, seated SLR is there. One SLR, the ideal SLR that we perform on the patients is when the patient is in a lying down prone position. Another, you can do it in a patient with a sitting position also. Another common test that we perform is the Bragard test. So if SLR is positive, okay, the lower the leg on the affected side just below the point of pain and quickly dorsiflex the foot. If the pain is increased, this suggests sciatic neuritis. Okay, so these are all confirmatory tests. Bragard test, hip flexion test, piriformis stretch test. Okay, you all can perform this test, but only after performing SLR, seated leg raise test. Only after that you can perform this test for confirmation. Now, diagnosis, very important. Now, diagnostic testing may include tests that can help determine any underlying medical disease. Obviously, here, most importantly, in cases of sciatica, we take the help of either X-rays or CT scan or MRIs. These are the most common tests that usually the patient might come to you with the reports of this test, or you might suggest if you think that your diagnosis is pointing towards sciatica, you might suggest the patient of undergoing any one of these common investigations to make your diagnosis more confirmed. Okay. Along with this, you can also study a EMG study, that is the electromicrogram, and along with that also sometimes patients are suggested to undergo nerve conduction velocity test for proper and more confirmed diagnosis. So whenever the patients undergo X-rays, there are different findings. Obviously, whenever you go through the X-rays, you see the AP views, the lateral views, and then you can X-rays. Obviously, they cannot diagnose accurately soft tissue conditions or degenerative disc disease or a clear herniated disc, but they can clearly show you about the vertebral structures, or if the spinal disc have lost their height or somewhat like that. Okay, if there is a reduction in the disc space, you can see it on an X-ray. MRI, obviously, it will show you very well defined images of soft tissues and bones, and it can also detect tears in the disc. It will clearly show you disc herniations or disc fragments. So yes, it is important. It can also diagnose or help you diagnose about spinal stenosis. Then CT scan or computerized axial tomography, that is CAT scan, again similar to MRI, more beneficial than X-rays. And in some cases, like what we do is before taking the pictures, a patient can be given a dye through a small tube that is placed in the vein, and then it can show better pictures of the muscles, of the blood vessels, of the sciatic nerve. So that is why this is used or gives you more specific investigatory findings. CSF findings in some patients, it is also important because the protein concentration in the CSF, it increases in patients with sciatica. Obviously, this is not a, let me tell you, let me confess, this is not a day in and day out procedure, but sometimes doctors need to undergo these investigations also. So protein concentration increases in patients suffering from sciatica, and the cause particularly is because of the leaking of plasma proteins through the blood nerve root barrier into the CSF. So obviously this is not a wasteful finding, but yes, it can guide you in certain complicated cases. So again, another is myelogram. Then scintigraphy can be done, PET imaging can be done. As I told you, nerve conduction studies can also be done. Yes, so coming to now, we are moving towards how we treat or take care of the sciatica. Now, along with treatment, along with physiotherapy, self-care at home is very important. You can ask your patients to use alternate hot or cold packs to reduce swelling and inflammation, and which will also help in relieving discomfort. You can always, or you must always, guide your patients to perform or to have good body postures while sitting, while standing, while walking, regular exercises. Obviously, whenever you suggest exercise, you must keep in mind that you are not suggesting exercises which can actually aggravate the condition, which can actually aggravate the pain. And you can guide the patients about how to lift any object. The first and foremost thing that you should tell your patient is don't do anything which gives pressure, which puts pressure, or which gives jerk to your lower back. No matter whatever or how important any work is, don't don't do certain maneuvers which will give jerk to your lower back. So that is what you can or you must guide your patient. As I told you, physiotherapy, it is far more beneficial whenever you treat a patient of sciatica. I have in my own research work seen excellent results of homeopathic medicines in sciatica, but whenever we suggest, categorically we suggest physiotherapy to the patients along with homeopathic medicines, believe me, the improvement level, they go a notch higher. Definitely you will see more improvement in patients who are undergoing physiotherapy. But yes, definitely with a proper trained or under the guidance of a proper trained therapist. Yes, as I was talking in my introductory lecture, yoga, as we all know, has answers to many, or I can say all the problems that mankind has. So even in cases of sciatica, there are certain poses. I am not a yoga master, so I can't describe, but this is what literature I have found, wherein there are certain top 8 yoga poses which can help you relieve the symptoms of sciatica. Preventing, again, it is somewhat similar to what I have described in self-care or adjuvant therapies that you can suggest to your patients. Prognosis of sciatica, this is important from our understanding as well as telling the patients, like most people, about 80 to 90% of the people, they fully recover from sciatica without surgery. This is what is most important to explain to the patient. And in most cases, the nerve is not permanently damaged, and individuals may recover in 3 weeks to 3 month time frame, depending upon the cause, depending upon how much the patient follows the what you can say follows the lifestyle changes that you have suggested, follows your treatment regimen, your diet regimen. If patient does all this diligently, this is a condition which has a very, very good prognosis, definitely. Yes, so coming to the homeopathic part, this was all about sciatica as a medical condition in itself. Now here homeopathically, obviously we say that we treat each and every individual individually. We take into consideration many factors before prescribing the remedy. But most challenging part while treating sciatica is to remove all the risk factors, because as we all know, they are the exciting and maintaining cause of this particular disease. And we refer to, or Dr. Henneman referred to as causa occasionalis in aphorism 7. So as per Sciatica, two aphorisms which I feel are more relevant are aphorism 147 and aphorism 252 from the 6th edition of Organon, wherein it is stated that whichever of these medicines, I'm talking about specific remedy. Okay, pardon me if I'm wrong over here, but this is very important to consider while treating the patient. Equally important when you give constitutional medicine, and this aphorism is also equally important. It states that whichever of these medicines that have been investigated as to their power of altering men's health, we find to contain in the symptoms observed from its use the greatest similarity to the totality of the symptoms of a given natural disease, the medicine will and must be most suitable, the most certain homeopathic remedy for the disease. In it is found the specific remedy of this case of disease. Okay, so it sums up everything. In short, wherever you need to use specific remedy, you need to use it. Aphorism 252, it states that the best selected homeopathic medicine in the suitable, that is the minutest dose, does not affect an improvement. This is sure sign that the cause that keeps up the disease is still persisting, and that there is some circumstances in the mode of life of the patient or in the situation in which he or she is placed that must be removed in order that a permanent cure may ensure. So this is about specific remedy and removing the exciting and the maintaining cause according to Organon. Again, if I go through the miasmatic approach, there are different types of pain in which, like different type of psoric pains, different type of psychotic pains, different type of syphilitic pains. Like I've just classified it as, the sciatica is because of any trauma, then there is no question of any miasm. If it is infective pathology, then it is post-herpetic neuralgia, it is of psychotic preponderance. If it is tubercular pathology, it is of pseudosoric preponderance. If it is fibrositis or inflammatory preponderance, then you can go towards psychosis. And if there is degenerative pathology like lumbar spondylosis, then it is of syphilitic preponderance. Repertorial approach, you can go through various repertories like Kent's repertory, where rubrics such as extremities, pain, lower limb, sciatica is given. Again, if you go through the sub rubrics, right, left, morning, night, it is given. Fartek's repertory is a very good repertory, very directly, because as we all know, it is a very classical clinical repertory. So direct rubric of sciatica is given. In Fartek's, you will find sub rubric of sciatica like ascending sciatica, sciatica which is aggravated on cuffing, flexing the leg amelioration. So these are some of the, yes, clinical repertory of J.H. Clark. It is one of the most important repertories if you want to confirm your materia medica with. So sciatica is a direct rubric given under this repertory. In synthesis repertory also, it is given in synthesis repertory. You will find a single remedy, that is Nephelium, which is a specific remedy I was talking about. A Nephelium, which is a specific remedy for sciatica. So in synthesis, you will find it under the rubric formication. Okay, so you can go through these various repertories. In complete repertory also it is given. Yes, yes. Before going to the cases, I would urge all the practitioners or all the student to define a criteria for assessment of your patient that I was telling you in the initial slides. Like how you will assess your patient, how will you assess whether the patient has improved or not, or because pain is a subjective feeling. As I told you, a pain you can forget, a pain you cannot forget, or a pain which makes you forget everything else. So you need to have certain criterias. You can classify this criteria as marked improvement, moderate improvement, mild improvement, no improvement at all, or the condition getting worse. Or along with that, this is one scale, the Dollier neuropathic scale, also known as the DN4 scale. It is a screening tool for any neuropathic pain. It consists of 10 items, which is grouped into 4 questions. I'll show you. Yes, this is. So this you can give to the patient to fill, the patients will take, or you can ask your patient yourself, or you can ask your subordinate to ask the patient, and the patient will help you in filling this form. And ultimately, you will get a score at the end of this. And depending upon that, you can classify whether your patient has improved or not improved, or whether the condition is stagnant or at a standstill. So this will help you in deciding your further line of treatment also. So keep in mind DN4 questionnaire, Dollar Neuropathic Scale, whenever you are dealing with cases like sciatica or any neurological entity. And this I was telling you about a visual analog scale, a simple scale wherein the patient has to rate the pain he or she is suffering on a scale of 0 to 10, where 0 is no pain and 10 is the worst pain possible. Okay, so I have certain cases. I think the time is getting up, so I'll not take much time. I'll go through the cases wherein specifically I have collected the totality of the symptoms. The patients who came with backache, wherein the extension was to the back of the right thigh. The patient had weakness in the lower extremities. Because of that, he was becoming restless. The modalities were there where he was better by pressure, lying on the back, and aggravated in the morning or rising from sitting posture. So ultimately, by collecting the personal history, the mentals and all, I was able, I'm just telling you or showing over here how homeopathic medicines are beneficial. So I did the repertorization, and after repertorization, the medicine that I gave was Ruta. I did not give the first medicine because, as you see, the majority of the symptoms were covered, or more number of symptoms were covered by Ruta. I gave Ruta, then I took follow-up, and in the follow-up, you can see that after almost 6 to 7 follow-ups, the patient was better almost 60%. After 40% improvement, the patient came, he was not better. But then after considering the condition, the symptoms at that time, again we gave the medicine, and again we repeated Ruta in a single dose, and after 6 to 7 follow-ups, the patient was almost better by 60%. In this case, another case, again, the remedy that I give after repertorization and after totality of symptoms was Nux vomica. And Nux vomica, obviously, we don't think of Nux vomica directly. But in this case, it was clearly prescribed. We gave that, and the patient was almost better by 80 to 85%. So it's a big improvement. As I told you, prognosis for sciatica is very good. 80 to 90% may get relief even without surgery. In the third case, the medicine that was given was Calicar. Again, not a medicine directly thought of in cases of sciatica. But when we gave, the patient was better about 75%. Some of the patients even stopped coming because 75 to 80% they feel as if now the pain has gone, no need to take the medicines. But this is still the last follow-up that we have taken. In another case, a clerk, obviously, as I told you, sedentary lifestyle came to us. We gave the medicine Rustox, and the patient was better by about 50%. This case is still going on. A female, a housewife suffering from lumbar spondylosis from last 2.5 years. She came to us. She was prescribed the medicine again, Calicar. See, in the 5 cases, 2 are Calicar. So we gave her, and then she is almost better by about 60% at this moment. So yes, this is, I'll stop sharing the slide. this is all I had to share in this short span of time about Sciatica. I hope I was able to explain in the most like easy way possible, because in the last few slides time was a little bit of constraint, so I had to go through it a little bit faster. I could not explain the cases in detail, but the bottom line remains. I would again sum up my session by saying that sciatica is very, very common day in and day out nowadays because of the postures and lifestyle of the patient. You will encounter patients coming to you with sciatica, and believe me, homeopathy, along with physiotherapy or certain other adjuvant therapies, has excellent scope in treating sciatica. Don't be prejudiced of giving certain medicines. I would suggest take into consideration the necessity of the patient, the condition of the patient when he or she is coming to you. If at all the time demands, the condition demands of giving instant relief to the patient with the help of a specific remedy, please prescribe. Help in allaying the pain of the patient at that moment. Along with that, do your proper case taking in your second or third follow up. Come up with a constitutional remedy, prescribe that remedy, but ultimately explain to the patient, educate the patient about sciatica, about the possible outcomes of sciatica, about the possible ways how homeopathy helps in sciatica, and the fear that sometimes nowadays patients come because they read anything on the internet and they come up with fears. So help in reducing those fears, and this is how ultimately as homeopaths we need to treat the patients, because only giving medicines is not the treatment. Counseling also plays a very big role, and explaining the patient about the condition that they are suffering is also the role of a doctor. So this is what I have to say, and I stop my presentation, and thank you again. Thank you to Homeopathy 360 for giving me this opportunity. Thank you.
Thank you so much, sir, for this very informational presentation. And we really find that sciatica is very common these days, and it was a very needful session. I would like to, request all the attendees to please put up your any queries or doubts in the question and answer box. Dr. Jolly,
Yes,
Dr. Jolly, please share the doubts or any questions if we have.
yes. Sir, there is a question about any dietary suggestions for sciatica patients.
Yeah, see, to be very frank, uh, till date I cannot find, maybe my reading must be less in that way, but I could not find a very substantial literature which suggests that a particular diet might actually help in relieving symptoms of sciatica. But when I was going through the literature, I was going through some of the Ayurvedic literatures in which they had suggested that patients suffering from sciatica or any neuropathies, or for that matter radiculopathies, should avoid sour things. So this is what I am telling you from what I have read, but till date I don't have any literature which can substantiate the claim that this is the diet chart that you should give to your patient. Just like we suggest physiotherapy, maybe a dietitian is a better guide. So as doctors, if we have in our circles dietitians, so we can take the help of the dietitian who can guide us to design a specific diet, keeping in mind the patient's totality. Again, as I told you in the cause, that obesity may be one of the causes of sciatica. So a dietitian might design a diet which might help a obese person, obviously. And in that way, it can help reducing the symptoms of sciatica. And we cannot deny the fact, obviously, dietary restrictions or dietary modifications in this way may help in treating sciatica.
Thank you, sir. Another question is, what is the meaning of painful cold as it was mentioned earlier in the questionnaire in DN4 criteria?
I didn't get you. Painful?
Painful cold. It
See,
was one of the questionnaire in
yeah.
DN4
In
criteria.
the Dollar neuropathic scale, yeah. See, painful cold in the sense, it is some patients, they suffer from sciatica or the condition gets aggravated during winters. So whenever the extremity is exposed to certain climatic changes, or for that matter, cold conditions, or a patient goes to a region which is cold, at that moment he or she might start experiencing more tingling or numbness or paresthesia or muscular weakness. So by that, that is what is actually mentioned in DN4 criteria, that is the cold pain. So whenever you want to ask the patient, you can classify or you can give options to the patient of asking such kind of questions. That is what is cold pain.
Okay, sir. Another question is, can tubercular pathology be cured by homeopathy or not?
In relation to sciatica?
So question is framed as, tubercular pathology can be cured by homeopathy or not? This is the question by one of the attendees.
Yes. Okay. See, again, first thing, curing or not curing, we cannot, as medical professionals, we cannot claim anything. Okay. So I would not go into the part of curing, but whether homeopathy can help tubercular pathology, whether we can help in reducing the symptoms, whether we can help in what you can say limiting the pathology, or we can help or reducing the pathology from going further on. So the answer is a definite yes, provided the patient surrenders to the doctor takes into consideration all the symptomatology of the patient, treats him or her diligently. I don't see any other reason of why we cannot treat. Rather than putting it as cure, we must treat the individual. And if you treat, obviously, you will be able to help that individual.
Sir, another question is about the any therapeutic medicines for sciatica, and another question is also any specific dose, potency, repetition.
See, again, there is no specific dose or repetition or potencies that we can suggest, uh, because obviously we need to work by the principles of homeopathy. We cannot go apart from there. But as I can see, or in some cases, definitely, I must agree that there is no time for doing all this. And in certain scenarios, whether like patients who are from the rural setups or from the villages, so they might not understand certain things, or they might not give you that much of time. So I don't say that homeopathy says this, but from my clinical expertise, what I have found is whenever you prescribe any specific medicine in 200 potency with frequent repetition, it gives us more, or it gives us good results, or it gives us fast results for that acute period of time. So this is what I can say from my clinical expertise, that 200 potency of specific meditation of specific medicine, sorry, in repeated in frequent repetition. So that is what I submit from my clinical expertise.
So one of the question is, because we have seen the cases, there were 30 potency medicines. So one of the attendees is asking, is 30 potency only should be given, or
No, 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 not like that, not like that. See, whenever I found it suitable, I took the case, I repertorized. Mostly the cases were given constitutional medicines, so I gave 30 potency. I do not advocate the case that only 30 potencies can be given. As I told just now, that if you are giving specific medicines where you don't have your symptomatology, you have very few symptoms, and you are prescribing direct specific remedies, please start with 200 potency with frequent repetitions. So that is not the case. It differs from case to case.
Sir, another question is, can you suggest any specific medicines for acute episodes, management of acute episodes of sciatica?
Yeah, definitely. See, Nephalium is the one. Nephalium works very well. Hypericum, obviously, it works very well. I have even seen excellent results of Lecnanthus, then Letrodactus. So, Nephalium, Hypericum, Lecnanthus, Lectrodactus, even Caliphos for that matter. You will be astonished. I have seen excellent result in a 8-year-old boy by giving Caliphos in biochemic form. So these are some of the medicines. Definitely, you can give it a try. Nephalium, Hypericum, Letrodactus, Lecnanthus. And one thing I am sure, these medicines will never disappoint you. If they give relief 5%, 10%, 20%, 30%, it might vary. But no patient will come to you saying, sir, मुझे 1% भी फायदा नहीं हुआ. I can vouch for that. These medicines will at least give some kind of comfort to the patient. That is for sure. This I'm telling from my clinical experience. No patient has come back to me saying, sir, could be farak nahi hua hai after giving this medicines. That is for sure.
Okay, sir. Another question is, any specific medicine for demyelination?
See, demyelination of the nerves is a like as I have shown in the miasmatic cleavage also. Whenever there is degeneration, or for that matter demyelination, it goes to the syphilitic preponderance side. Whenever there is degeneration of the myelin sheath that covers our nerve, ideally speaking, once your myelin sheath is damaged, it cannot be regenerated. It cannot be regenerated. That is what medical science says. So we cannot say that I'll give a XYZ medicine and the myelin sheet will be regenerated. In this case, what you can do is, by proper selection and by proper prescription, you can prevent the condition from worsening further, and giving some symptomatic relief to the patient, or keeping the condition at a standstill so that it does not progress into some complications. So that is what you can do in cases of demyelination. But as far as my knowledge goes, once the myelin sheet is damaged, it cannot be regenerated, medically speaking.
Sir, next question is, if sciatica is arising after surgery of leg, how should we categorize it?
Categorize in the sense, see, again, I would put it into traumatic cases only. Because if we say after surgery, so some kind of trauma during surgery might have or may occur. And because of that, the sciatic nerve may directly get irritated, or because of some other operational procedure, something might compress the lumbosacral trunk or the sacral plexus. So it can be categorized into traumatic sciatica. But again, as I told in my initial slides, sciatica is basically a set of symptoms. So you must look into that after surgery, what your patient is having, whether your patient is having only pain, whether your patient is having only tingling and numbness, whether your patient is having only muscular weakness, or whether the patient is having combination of some symptoms, or the patient is having combination of all the symptoms. So, so this is what you need to look at before treating, even if it is after surgery.
Sir, only one question is left, so I'm asking the last question. One attendee has mentioned that, sir, as you said, we can use specific remedy, but under what conditions we should select specific remedy? Because when we repertorize case, we get most common remedies for sciatica.
Yeah, this can be answered in two ways. One, I think I've already answered that in what cases you can give specific remedy is obviously you are not getting the ideal symptomatology for your proper repertorization. In that cases, you can give specific remedy, or in certain situational conditions wherein at least immediately you need to give some relief to the patient, so that can be given. And another point for this question is that whenever we repertorize, we get most common remedies for sciatica. I think that is not the case. Even in the cases I went it through very fast, but we saw that we got Nux vomica, we got Kalikar. So those are not common remedies for sciatica. See, again, there is no concept of common remedies. There is nothing common, because for us, the most important thing is uncommon and characteristic. Okay, so common things are obviously useful for diagnosis. But yes, whatever uncommon is there, whatever characteristic is there, you must focus on that. And you should not have the pre-notion that whenever you will repertorize, you will get only common remedies. That should not be the pre-notion that we should keep in our mind while treating the patient.
Thank you, sir. The questions are over, but one of the attendees has requested you to take another session on knee pain and its treatment, and others are also just thanking you for the informative session.
Yes, yes, definitely, definitely. Thanks a lot. Thanks to all the participants for bearing with me since the last 1 or 1.5 hour. And thank you for spending your valuable time and your inputs also, because your questions, like the question about diet, I think I have become more inquisitive about it now, and I'll go and research on it, that how diet can be helpful, because that can be an additional advantage or additional benefit that we can pass on to our patients. Thank you.
Thank you so much, sir. And no doubt, session was really very informative, and it will be very helpful for all the students and, of course, for the physicians also. We see sciatica is getting very common these days, and we obviously face difficulties while approaching the case of sciatica with a homeopathic approach. You guide us very well, sir. Thank you so much for your time. Please share your reviews with the Homeopathy 360, sir. How was the
Yeah, yes,
experience?
sure. Sure, sure, sure. Thank you, thank you. Thanks a lot, Dr. Mansi. Thank you, Homeopathy 360 team. They have been wonderful. Thank you, Jolly, for being the coordinator. See you tomorrow exactly at 9 o'clock, Jolly.
Sure, sir.
Thank you so much, sir.
Thank you, thank you. Thanks a lot.
Okay.